Hi everyone and welcome to the Emergency Physicians ECG course. This is Hesham Ibrahim. I'm one of the emergency medicine consultants in United Kingdom, and today is going to be a special discussion. We are going to revisit our case number 43 and carry on with part 2 of the discussion for this case, and I will explain a bit later why we're doing this. So the case that we're going to talk about is a case of a 42-year-old lady who presented to ED with intermittent palpitations with mild shortness of breath of acute onset for a few hours. There was no previous medical problems with her, and her obs were all okay apart from that she's got a slow heart rate, and this was her ECG. So this is an ECG that we've discussed in case number 43, and let's go through it again. So let's analyze our ECG for the second time. So this was the ECG, and we've learned in the previous discussion that we have to have a system going through ECGs. So checking the rate, she's on the brady side, so we've got bradycardia here. The rhythm in terms of the regularity looks regular to me, and again we've covered this before. Complexes are narrow, so we've got narrow complex regular bradycardia, and the axis, it looks okay to me here, so normal axis. Then moving on to the other questions, we have to ask about the P waves and the intervals. We're going to delay this for a few seconds. Then chamber enlargement, and I don't really think that I can see any signs of chamber enlargements here. And from the ischemia point of view, we've got few T-wave inversions in V1, V2, V3, and we've got T-wave inversion in lead 3 and maybe in AVF as well, but no ST changes, no ST elevation or ST depression, and that's all what we have in here. Then we're gonna focus for a little bit on the P waves and the PR intervals. So we decided to split the ECG into two halves, and in this half of the ECG, it was quite clear to all of us that we've got absolutely no problems with the P waves and the complexes and the PR intervals. So we've got a normal looking P waves, normal looking PR interval, normal looking complexes, so no rhythm issues here. But the first half of the ECG showed these abnormalities here. So we've noticed that we've got P waves that are after the complex in the first 3 beats, and then within the complex in the last one. So the complexes were still the same, still narrow, but the P waves happened just after the complex or within the complex. So that was the difference between the first half of the ECG and the second half of the ECG. So that is just to clarify again the two halves. So this is the rhythm strip from the second half, and we can clearly see normal looking P waves, PR interval complexes, and everything is nice and regular and in the right direction. So again, that's normal. While in the first half of the ECG, we've noticed that the P waves came after the complex in the first 3 beats, then within the complex as part of the complex in the last one. And if you remember, our diagnosis in the previous case was junctional rhythm. So we discussed all sorts of junctional rhythms in the previous case, and now we're going to revisit the case, and that is for that reason. So I've received a very interesting question about the case, which was, why not isorhythmic AV dissociation? Why did he say junctional rhythm and not isorhythmic AV dissociation? So to be able to answer this question, we'll need to revisit everything and talk about some other important concepts as well. So let's start by talking about normal sinus rhythm and define it in the ECG. So normal sinus rhythm means that the pacemaker of the heart is the SA node. So the impulses, the pacemaker, are all coming from the SA node. This is the pacemaker now. That is what normal sinus rhythm means. And then the impulse will spread to from right to left, from where the SA node is to the other side of the heart, to the left side, and downwards toward the AV node. And in the ECG, you must have, to fulfill the definition of normal sinus rhythm, you must have positive P waves in lead 2 and negative P waves in lead AVR. To have the two, we will call it normal sinus rhythm. If you do not have the two, or if you do not have one of them, that means that this is probably not a sinus rhythm. The SA node is not the pacemaker of the heart. So, what if this is not the case? What if it is not normal sinus rhythm? So, let's quickly revisit what we talked about when we discussed the junctional rhythm. So we said the following. If this is our heart, and again, so 4 chambers, SA node is here in the right atrium, AV node is here in the right atrium, then we've got the bundle of His and the left and right bundle branches. So what happens with the junctional rhythm is somewhere within the AV node or nearby the AV node, it will be the focus, the firing focus, that will fire up to stimulate the atria and will fire downwards to stimulate the ventricle. And the stimulation to the ventricle will happen via the normal pathways, the normal connecting tissue, conductive system. So basically, the outcome is going to be a narrow complex. But because the firing focus is nearby the AV node, it means that the PR interval will be very short or maybe absent. So stimulation above and below the AV node will happen either simultaneously, or the P wave will be just before or just after the complex. So that is the first fact to know about the junctional rhythm. Second fact is, normally, if the SA node is the pacemaker, the direction of the wave will be from above downwards. But in junctional rhythm, the direction is reversed. We are stimulating the atria from below upwards. So the P wave will be inverted. So first difference between normal sinus rhythm and junctional rhythm is that the P wave will be inverted because it's not sinus. So it will be inverted in lead 2 and upright in lead AVR. And the second difference is that the PR interval will be either very short, like in here, or it will be hidden within the complex if the stimulation to the atria happened in the same time of the ventricle, or it will be just after the complex. And again, it will be an inverted P wave after the complex. So these are the two differences. So first is the P wave will be inverted in where it should be upright, and will be upright where it should be inverted. So it will go the other way around because the stimulation coming from below upwards. And second difference is that you will have a very short PR interval, or the P wave will be hidden within the complex or shortly after the complex. So that is what happened with junctional rhythms. Here's an example of one of my patients who came in with junctional rhythm. And as you can see here, the rate actually is within normal. So that is an accelerated junctional rhythm. And if you look at the rhythm strip, you will notice that we've got, so let's look at lead 2. So P wave is inverted in lead 2, very short PR interval. P wave is upright in AVR, very short PR interval. The P waves happen just before the complexes, nothing within and nothing after. So that is an accelerated junctional rhythm. So let's make things a bit bigger. That is AVR, and we can clearly see here that the P waves are upright just before the complex. And here's the rhythm strip, and we can see that we've got an inverted P waves in lead 2. That is just before the complex, so a very short PR interval. So the diagnosis here is junctional rhythm. So that was the first topic that we wanted to cover, which is junctional rhythms. How about AV dissociation? So that is another topic that we need to cover here. What is AV dissociation is the first question. So AV dissociation is a condition in which the atrial activation, and it's usually coming from the SA node, happens independent from the ventricular activation. So you will have two firing foci that are firing in the same time independently. So you will have, if this is our heart, you will have SA node that is firing from above, and then you will have another firing focus somewhere either next to the AV node or below it, somewhere in the ventricle, firing to stimulate the ventricle. And the atria will not be talking to the ventricle, hence the AV dissociation. So the P waves will be regular because they're coming from the SA node and firing as normal. The QRS will be regular because they're coming from another focus somewhere either in the AV node or below, and again they will be regular, but they will not be mapping each other. It's not going to be PQRS complex, PQRS complex. No, they will not be talking to each other at all. Okay, let's go a bit more deeply with that. So let's talk about the different forms of AV dissociation that we know. The first form, and the commonest one, is the complete heart block. So this is the commonest form of AV dissociation that we're aware of, and in which you get an atrial rate that is more than the ventricular rate. So in complete heart block, the number of P waves will be more than the number of the complexes there. So we have in this rhythm 1, 2, 3, 4, 5, 6 P waves for 1, 2, 3, 4 complexes. So the number of the P waves is more than the number of complexes, so the atrial activity is higher than the ventricular activity, and they are not talking to each other. So there is you cannot really predict when the next complex is gonna come or the next P is gonna come in relation to each other. So that is the complete heart block, which is the first and commonest form of AV dissociation. Second one is the interference AV dissociation. You might not have heard about this term before, but actually you know the example for this. This is the second form of AV dissociation where you get a ventricular rate more than the atrial rate. So it's the exact opposite to the complete heart block. So the ventricular rate is going to be firing far more quicker than the atrial rate, and the best example for this is VT. So in VT, you have atrial activities that you will be seeing every now and then. Maybe this is a P wave, maybe this is a P wave, I mean, who knows? But there will be some atrial activity happening hidden within the complexes, and the atrial rate will be definitely less than the ventricular rate, and all what you will see in the ECG is going to be mainly just the runs of the complexes. So that is the second type of AV dissociation. You cannot really say that these P waves are doing anything with that ventricular rate. So that is the second part of the AV dissociation, which is the interference AV dissociation. Third part is what's called isorhythmic AV dissociation. So in this form, the third form, you get a ventricular rate that is equal to the atrial rate. So the number of P's will be the same as the number of QRS's. So let's talk a bit more about this type. Isorhythmic AV dissociation. So it is a condition that happens when the atrial rate is equal to the ventricular rate, and they look like they're communicating. The atria, they look like they're talking to the ventricles. The P waves, they look like they're talking to the complexes, but actually they're not talking to each other at all. And it can happen with or without complete heart block, and I will explain this in a few minutes. So the atria are stimulated by the SA node, and the ventricles are stimulated by another focus that is somewhere nearby the AV node. so junctional impulse. So if we draw our heart in here, and again, this is the Iso node and this is the AV node. So the Iso node will be firing on regular basis to stimulate the atria, and it will give you kind of regular P waves that are upright in, sorry if they're not that regular, but they have to be regular. So P waves that are upright in lead 2 and inverted in lead AVR, because they're coming from the Iso node. So that is a normal sinus rhythm looking at the P waves. But they are not going to cross this point. They're not going to cross the AV node down to the ventricle. They will stop there, and there will be another focus nearby the AV node that will be stimulating the ventricles on regular basis with the same atrial rate. So the complexes will happen kind of, let's say, here, but they might happen over the P wave, or just before, or just after, and again on regular basis. So there will be a complete AV dissociation, but without a complete heart block, because you can fix this, and we will talk about how very soon. So this is the pathology of the isorhythmic AV dissociation. And in isorhythmic AV dissociation, it represents a synchronized AV dissociation. So synchronized means that you get a 1-to-1 ratio between the P wave and the complexes. For each complex, you will get one P wave. So that is synchronized, but it is an AV dissociation because actually they work both independently. The contractions of the atria is independent from the contractions of the ventricle. The P waves are not talking to the complexes. They are not transmitted to produce complexes. So it is a benign condition, the isorhythmic AV dissociation, and it is seen in about 20% of athletes. And the ECG criteria for it is you get a sinus rhythm, which means, as we know now, positive P waves in lead 2, negative P waves in AVR. You get an atrial rate that is equivalent to the ventricular rate. So you might feel that they're talking to each other, but actually there is a complete AV dissociation. So the P waves can happen before, during, or just after the complexes. So the question is going to be, what's the difference then between the AV dissociation and complete heart block? The answer is, in AV dissociation, this is a term that is commonly used when the ventricular rate is more than the atrial rate, like in VT. So in VT, you cannot really say that there is a complete heart block, but there is definitely an AV dissociation because the P waves are not transmitted to produce an impulse. And while with complete heart block, it is used when the atrial rate is more than the ventricular rate. So first difference is with the AV dissociation, the atrial rate is usually less than the ventricular rate, while with complete heart block, the atrial rate is more than the ventricular rate. Second difference is not every AV dissociation is associated with complete heart block, like in VT, for example. This is an AV dissociation, but it is not a complete heart block, while every complete heart block is associated with AV dissociation, because part of the definition of complete heart block is that the atria are not talking to the ventricle. Okay, so there is a difference. You cannot really call every AV dissociation a complete heart block, but you can call every complete heart block an AV dissociation. Second question is how to differentiate then the isorhythmic AV dissociation from the complete heart block. The answer is going to be by increasing the atrial rate. Whether you do this by getting the patient to do some exercise via treadmill or to walk in the department, or via giving drugs like atropine to increase the heart rate. If you increase the heart rate in isorhythmic AV dissociation, the normal AV conduction will be restored because the AV node is not diseased itself. So if that happens, if you increase the heart rate, you will restore an absolutely normal sinus rhythm once you increase the heart rate. While with complete heart block, if you give something to increase the atrial rate, the atrial rate will increase, but the ventricular rate will stay the same because there is a complete isolation between the atria and the ventricle. There is a complete heart block that will stop anything from going through to the ventricles from the atria. So this is how to differentiate the two conditions, and it is really important to differentiate because the isorhythmic AV dissociation is a very benign condition, and you can easily send patients home with it. While with complete heart block, that is a serious condition that usually requires a pacemaker and requires a hospital admission all the time. So by all means, you have to differentiate the two, and this is how to do that. So let's go back to our case so we can actually answer the question whether what we've seen in this case was a junctional rhythm or it was an isorhythmic AV dissociation case. So here is the ECG, and first thing to check here is to check the number of P waves to the number of complexes. We've got only one P wave for each complex, so this is going to be either a junctional rhythm or isorhythmic AV dissociation. Then let's look at the P waves. The P waves in lead AVR is pointing down, so negative. In lead 2 is pointing up, is positive. So first of all, the impulses that are producing these P waves are coming from the SA node because we've got here a normal sinus rhythm. This is a sinus rhythm because the P waves are inverted in AVR and upright in lead 2. So let's make things a bit bigger. Here's the second half of the ECG. Everything is absolutely normal. Here's the first half, and as we can see here, P waves are inverted in AVR. P waves are upright in lead 2. AVR inverted P waves. Lead 2 upright P waves. So that means that this is a sinus rhythm, so it cannot be junctional rhythm to start with. And then we've got the variation between the relationship between the complex and the P wave. So here the P wave is just after the complex, actually coming from the end of the complex. Here it is after the complex, separated by a small distance. Here the distance is a little bit bigger, and here it is merged with the first half of the complex. So there is absolutely no relationship between the complexes and the P waves. And the P waves are coming from the SA node, which means that our final diagnosis here should be isorhythmic AV dissociation rather than junctional rhythm, for the reasons that we've just explained. So what happened to this case, as we've explained before, is that she received some atropine, and with atropine, the rhythm started normalizing again. So just by increasing the heart rate for a little bit, the P waves, if we look at here, the rhythm strip, that is the best one. So we've got P normal PR complex, P normal PR complex, P normal PR complex, and it keeps happening throughout the whole rhythm strip. So everything started to go back to normal just by giving a small dose of atropine to increase the rate for a little bit more. And actually, we could have done something different and just got the patient to walk around in the department to increase the heart rate for a little bit, and that should have normalized the rhythm as well. So this was the second part of the case that we've discussed before. I'm really sorry I've got it wrong the first time. I thought a lot about removing the first video not to confuse anyone and just put it all in the correct format. But after reviewing the previous video, I found loads of learning points that we can use in the previous video, and I wasn't really happy to lose this. So I thought, fine, I'm just going to put a second part to explain everything and give the correct answer at the end. So the final answer for the case was isorhythmic AV dissociation, and here is a summary of the learning points here. So about isorhythmic AV dissociation, so this is a condition that happens when the atrial rate is equivalent to the ventricular rate, and it happens with or without complete heart block, and it is a benign condition that could be easily fixed by increasing the heart rate. So The ECG criteria to diagnose isorhythmic AV dissociation is going to be sinus rhythm, which means P waves in lead 2 that is positive and negative P wave in AVR. Atrial rate is equivalent to the ventricular rate, but with AV dissociation. So the P waves can be just before or during or just after the QRS complex. And this is it regarding this case. Sorry if it was a long one, but it was full of learning points. And let's finish now with this great picture of Taba in Egypt. And thank you very much for listening, and I'll be talking to you very soon. Stay safe and bye for now.